Now I have the privilege of introducing today's speaker. Dr. Ginger Borges received her medical degree from the University of Medicine and Dentistry of New Jersey Medical School, and received her master's in medical sciences from Harvard University and Massachusetts Institute of Technology. Dr. Borges has been at Anschutz Medical Campus for 20 years and is currently a professor of medicine with tenure. In addition, Dr. Borges holds the John C. and Patricia Young Connor Endowed Chair in Young Women's Breast Cancer. She is the Deputy Head of the Division of Medical Oncology, the Director of Breast Cancer Research Program, and is also the Director of the Young Women's Breast Cancer Translational Program. I would like to take a moment to thank Dr. Borges for being here today. We will give her a moment to pull up her slides, and then the floor is yours, Dr. Borges.
Thank you so much, and it's happy to be here, everyone. Just Ginger, and we'll be happy to take questions as we go along. I'll also take breaks as I'm presenting the slides here and there to share things with you. So I'm gonna click over into slideshow. How do those look to you guys? Excellent. All right. It's a huge topic, so it's going to be pretty broad strokes overview. And I'm going to start off with just some basics about the breast cancer risk, move into some of the basics of how we think about it when we treat it as medical oncology and a multidisciplinary team. And, along the way, if anything I say is unclear or you want more information about it, feel free to put it in the chat or raise your hand. I'm pretty facile with doing things over Zoom, so we'll see how it goes. And I am going to bounce back and forth and change presentations at one point just because I want to make sure I'm covering everything, and I have this batched in a couple of different slide sets. So just starting to talk about breast cancer in general, want y'all to be aware of the fact the breast is actually a bigger organ than most of us realize. So mammals have mammary glands, humans have breasts, and what makes them different is that they don't really evolve until we go through puberty, but then we have this existing gland whether we are pregnant or lactating or not, whereas in mammals that only happens during pregnancy and lactation, and we have two of them, whereas mammals have more. It does, have breast tissue can go all the way up to the collarbone, all the way out to the tail of the axilla. So if you ever spend time with us in the breast clinic, you'll see sometimes we have patients whose tumors are very high up on their chest wall or way out in their armpit, and lots of area to think about and cover. The breast itself is kind of like a tree. There are the ducts and then there are the lobules, and the ducts are equivalent to the trunks and the branches, and the lobules are equivalent to the leaves in summer. And so there are more trunk and branches than there are leaves, which is why we see a larger amount of ductal cancer as opposed to lobular cancer. But those terms just discern from where the parent cells are that the cancer would have arisen. In the United States, as we age, the likelihood of getting breast cancer goes up, particularly for women. Once we cross through into our menopausal years, the risk goes up quite a bit. The risk is highest in white women in the United States and lower in women of Black or Latina descent and Asian descent for reasons that we're still trying to figure out. But when you hear about the statistics of 1 in 8 women will get breast cancer, and you see those pink ribbon statistics, I call them, it's because by the time we get to being old, 80 or older, that's what the risk looks like. But there is a risk no matter how old we are. And in general, breast cancer can begin as young as the late teenage years, although really once we see 20-year-olds is where we see the risk starting to go up. And then by decade of life, it starts to go up quite a bit. But young women can get breast cancer. And as many of you know, that's what I specialize in. So we want to make sure everybody is aware of their risk and understanding changes in their breasts and seeking attention if they identify any. Unfortunately, breast cancer is a pretty big problem globally, and it's a disease of pretty bad disparity, right? So these numbers have increased, but back in 2012, it was about 1.7 breast cancer cases. This is now closer to 1.7 million. This is now a little bit closer to 3 million. And the majority of deaths from breast cancer that occur worldwide definitely are happening in the developing world. So countries in sub-Saharan Africa or Africa, parts of South America, India, Far East Asia, the Caribbean, parts of Central America have much higher death rates due to breast cancer in comparison to places like us in North America or the European countries or Australia, where there's pretty evolved medical care. What are the risk factors for getting breast cancer? Well, you'd be surprised that most people forget that the number one risk factor would be being a woman, but men can get breast cancer. And in the age of the modern world, where we have folks who are using various medical techniques to realign their gender over time, we don't know what that will do for risk of breast cancer. But because those are hormone-driven procedures, we expect that that could change those people's risk as well. As I said, the older we get, use of hormones increases our risk. So oral contraceptives, hormone replacement therapy. DES is a drug that was given a long time ago to pregnant women who were having a lot of nausea. We don't give this to people anymore because it causes cancer in them as well as their offspring. But that's one of the old exposures from our history. Then each of us have individual reproductive factors. How old are we when we get our period? When do we go through menopause? Do we have children? Do we nurse those children or not? Do we gain weight after we go through menopause? All of those will influence somebody's risk of getting breast cancer when they are in their later years, 55, 65, 75. Things that increase young onset breast cancer or any age breast cancer is if that person had a prior cancer, such as like Hodgkin's lymphoma, and ended up getting radiation treatment, and that radiation treatment overlapped with their breast tissue, that increases their risk a lot. Unfortunately, the use of alcohol is associated with the increased risk of getting breast cancer, particularly if it's combined with increasing use of alcohol and gaining weight as women go through menopause. And any level of alcohol causes a small increased risk, although certainly in moderation. 1 drink a day for women, 2 drinks a day for men has less risk than if somebody is consuming more. We know that exercise is good for preventing breast cancer, so the total lack of exercise is bad. And the data on extreme athletes actually is uncertain, but probably in general, exercise is good. And I want you to take that away as a message here. Some folks have a strong family history of breast cancer or other cancers, and there are 9 genes that are associated with getting diagnosed with breast cancer from having inherited one of those genes from a parent, BRCA1 and 2 being the most common known, but there are 7 others. So we really encourage people to know their family history, have a sense of their personal risk. And if it seems like they are from a high risk family, we want them to come in and get counseled as to whether we should be looking at them differently. And of course, anyone who's had a prior pre-malignant biopsy on their breast has a higher risk of getting breast cancer into the future. I'll skip that. I'll go back. So when we see breast cancer, it comes in 2 forms. It can be abnormal cancerous cells that have not yet broken through the duct and are in place or in situ, and that's what breast cancer in situ stands for. And there's 2 forms, ductal carcinoma in situ and lobular carcinoma in situ. And this gets confusing because you would think DCIS leads to invasive ductal and LCIS would lead to invasive lobular, but it doesn't. So LCIS is considered a precursor lesion and a marker for someone who is likely to have an increased risk of getting diagnosed for breast cancer, but not in the exact spot where these cells are seen. So this is not treated as cancer, it's treated as a cancer risk. Conversely, DCIS is cancerous cells that left in place we think are having some risk of transforming into a full-blown invasive cancer right there into their future. So you will see us in clinic treating DCIS as something that has to be surgically removed in order to cure the patient and prevent those cells from transforming into an invasive cancer. So that's what I just said about the lobular carcinoma. And this is more frequent in premenopausal women. And also we see it often in women who have a lot of exposure to hormones. And this is what it looks like under the microscope. It's just sheets of very uniform cells. These almost look like white blood cells. These cells tend to be small and very similar looking to each other. And that's an up close view. And how do we treat LCIS? Well, like I said, since we don't think it is cancer, but a precursor for cancer, we offer prevention. So prevention comes in the form of drugs such as the tamoxifen or raloxifene. There's also aromatase inhibitors, and there's a recent study looking at something called baby tam, which is a low-dose tamoxifen, all of which has been shown to reduce the risk of a patient with a finding like LCIS from going on to getting invasive. Back in the day when I was very young in my career, they actually would also offer women bilateral total mastectomies as prevention, but we think that's a very extreme situation. So we only talk to women about that in the modern era if we also find something like one of these genes, BRCA or et cetera, where we think their risk of getting breast cancer is super high and the prevention might not benefit them. DCIS is different. It's a precursor clearly to an invasive cancer, and it has many different appearances under the microscope. And that's what we talk about it. So you'll hear us call it solid DCIS. Well, that's this one where all the cells look the same. Cribiform means it looks like a brain. It looks like the architecture of the brain. And then this type, the type that's the most aggressive, we will call chemetonecrosis because it looks like it's got some inflammatory cells or almost pus-like cells sitting inside of what is otherwise cancerous cells. But none of these have broken through and invaded into the next door area of the breast tissue. So these can all be cured with surgery alone. And when we look at DCIS, we look at how the cells look like under the microscope. Do they look very normal, not so normal, more ominous looking? You see these big guys and how there's all these changes in the nucleus. So that would be considered low, intermediate, or high grade for DCIS. And that also helps us factor into what is a cancer DCIS that is going to be more likely to become invasive, like this high grade, versus less likely to become invasive, like this low grade. And so how do we treat this? Depending on the age of the patient and their choices, we could simply do surgery on it, particularly if it's an older patient and they're willing to think about taking hormone therapy. We, for many years, will also do surgery and then have the patient undergo radiation. And in the modern era, there's testing they can do on that tumor sample to figure out if radiation is worthwhile. Or the patient could also undergo mastectomy, and then they would not need to consider radiation. So then, when does breast cancer become more serious, potentially life-threatening? It's when it crosses over from DCIS into being invasive. And when I try to explain this to newly diagnosed patients, I explain the analogy of DCIS is kind of like Anakin Skywalker, and invasive breast cancer is Darth Vader. One has more evil and more capacity to do harm than the other. And amongst invasive breast cancer, there's many different types. The big distinctions is the ductal and lobular that I talked about before. But then within ductal, there's a bunch of different descriptors of things that either have better prognosis or more concerning prognosis, the micropapillary. There's also the lobular, and that has two different versions to it, the pleomorphic being more aggressive. And then there's all these other types as well. Inflammatory is a really unique form of breast cancer where it presents more like a rash on the breast or an infection. And that's an extremely aggressive form that can be very hard to treat and take care of. Staging of breast cancer is complicated because we have the, by the way, can you guys see my pointer? Can you see it if I do it over here? Were you seeing it before when I did it over here?
No.
No, I can see it.
So I just have to look at my other screen. So I'm sorry, you're going to see the side of my head. So there's the anatomic staging of breast cancer that's been around for forever, which breaks it down to the T, or the size of the tumor, the number of nodes involved, and whether or not it's metastatic. And oddly enough, anything stage 3 and less technically meets the criteria of early breast cancer. So stage 4 or metastatic is advanced breast cancer. That's not what we're talking about today, but really the term early breast cancer is all of this. Now, what gets confusing is in the most recent version of staging, not only do we factor this anatomic staging in, But we also add into it the markers that we test for breast cancer, the subtypes, estrogen receptor, progesterone receptor, and this thing that I'll talk about more in a few minutes called HER2. And these predict for the cancers that are going to behave better or worse. ER positive is better. HER2 positive is extremely aggressive, but with modern treatment, quite curable. And the triple negative, or negative for all three of those markers, tends to be the most aggressive and can be very problematic to treat depending on the stage that the patient is diagnosed. So we now interweave these on top of each other. We have the anatomic staging, we have the prognostic assessment of the tumor. And so you can sometimes see in one of our EPIC notes that the patient's tumor will be big, maybe no lymph nodes involved, but because they've got good biology, it actually pulls it back to a prognostic category of stage 1, even though for clinical trial purposes and when we're talking about putting patients on study, we would still go by the anatomic staging and call them stage 3. And if you think it's confusing to figure out who's going on a study, imagine how the poor patient feels that she has stage 3, but it's really 1 breast cancer, or it looks like a stage 1, but because it's triple negative, now we're telling her she's stage 2. Very nuanced, problematic concepts sometimes, particularly in the clinic. Let me get my cursor back over here. Well, I'll just do this. So in the olden days, the idea of breast cancer was you would just do as big a surgery as possible and get local control. And that was where the field was for hundreds of years. Beginning about 30 years ago and into the modern era, it's the understanding that even the smallest tumors can send a small cell out into the bloodstream that can be harboring there as dormant metastatic disease. And so we have to apply systemic treatment to just about all cancers in order to maximally prevent the risk of them having recurrence. So surgery and radiation is for the most part for the local control of the tumor, while the systemic disease is to make sure that we kill off those minimal residual disease cells and maximize the chance of curing the patient. When we talk about breast conservation, what we mean is that we are going to remove just the tumor and sample the lymph nodes under the armpit, but we're going to leave the breast in place. And interestingly, it doesn't necessarily have to do with just the size of the tumor, right? It's more the tumor to breast ratio, because what one woman could have as a lumpectomy would be the equivalent of practically a bilateral mastectomy in another woman's breast, depending on whether she, how long the titty fairy spent in her life and how big she ended up at the end of her puberty. Some women also get diagnosed with multiple tumors, and the location of the tumor can matter. There's places in the breast that are easier to do surgery and leave what's left behind looking like a natural breast versus not. And again, these different subtypes of cancer can inform whether there's going to be a good chance at breast conservation. Decades ago, there were very large randomized clinical trials to prove the point that you could do radiation after a lumpectomy and it had no worse outcome in terms of the development of metastatic disease or the cure of the patient in comparison to a mastectomy. And so this is old history, but it's how we got to where we are today, to feeling like these are both equal options. And the fun thing to realize is that these studies were driven by women who had gotten breast cancer. They were not accepting of the fact that they were just being told to have a mastectomy no matter what, and they challenged the field to design these types of trials, and it worked. They were right. They didn't have to have mastectomies once we had the technology of radiation to improve our field and be able to offer breast conservation. Another big evolution that came about years ago is this thing you will hear about called a sentinel node biopsy. So in the olden days, when women went to surgery, the surgeon would also just do a great big lymph node dissection in their armpit and remove 10, 20, 30 lymph nodes. And at the time, that was cutting edge, but it left those women with a lot of scar tissue and harm to that part of their body. So this concept that the breast all drains to just a couple of lymph nodes allows our current surgeons to give the breast an injection of a dye or a radio-labeled tracer track that in the OR and only remove 1 or 2 or a small number of lymph nodes to which the breast is draining. So that's the word sentinel is kind of like the guard, right? Like the Swiss guards that stand outside the Vatican, they're called the sentinels. And so this is the same concept. It's the lymph node that's guarding the rest of the body from anything that might be coming out of the breast. And this technology has been in place for many years, so much so that we now have patients who will have a sentinel lymph node biopsy and not need any further surgery on their armpit. So it's been a big revolution and an improvement in the quality of life of our patients because it limits the amount of lymphedema or bad outcomes and problems they will have to deal with on that side of their body in their future. So what we know about radiation is that it sterilizes where the tumor was in the breast and the chest wall. And many studies have shown the value of it and that we can give radiation to the breast and the breast tissue tolerates it well and still looks normal afterwards. We also know that if a woman has lymph nodes involved at the time of her surgery, if we give her radiation, it will improve her survival outcomes. So who do we think is a good choice for this? Anyone who's had that DCIS and had a lumpectomy, if their cancer shows that they would benefit from the radiation, we do it then. We do it for small tumors after a lumpectomy. We do it to the entire chest wall plus the lymph nodes for very large tumors or women who've had positive lymph nodes, or if for whatever reason the surgeon wasn't able to obtain clear margins at the time of their surgery and there's tumor right up against the edge of where they were operating, sometimes we have to consider it then. And then, of course, even when we do surgery and radiation for our patients, the cancer can come back right along the same spot of the chest wall. And so we will reapply radiation if it was not used. And sometimes we can even give it twice, depending on the exact situation, to still try and cure a patient, even though her cancer's recurred once. That's how they do planning with radiation. They use a CAT scan machine and they figure out where the tumor was. That's what the green asterisk is. And then they do planning to figure out the dose. And what they really want to avoid is, of course, this thing here, which is the heart. And there'll always be a tiny rim of the lung caught by the radiation field. And we will see changes in that area in our patients' CAT scans for the rest of their life, but it's a teeny little area, so it seldom offers them any complications to their exercise vitality or their pulmonary function as life goes on. And of course, one of the most important ways for us to benefit our treatments is to try and cure them, but cure them in ways that minimize the negative effects. And the best way to do that is to only give the therapy to patients who truly benefit. And that's what the most recent decades of cancer research have looked like. So chemotherapy came along in the 1970s, and it evolved over decades with, for the longest time, we didn't have very many drugs. So it was just kind of like alphabet soup of rearranging all of these drugs, which are all kind of the same drugs, to figure out different ways of doing it. And we used to give very high doses of these, which caused a lot of late side effects. We even also used to do bone marrow transplant for breast cancer back in the beginning of my career, and that ended around 1998. Taxanes, which we still use today, paclitaxel or docetaxel, also known as Taxol and Taxotere, are still a part of our armamentarium, and we're still giving Cytoxan and adriamycin, which is AC, today, even though all these drugs began their history in breast cancer medicine many decades ago. But we've gotten a lot more sophisticated about how we give it. Many years ago, we only focused on how many lymph nodes were involved because that would affect the likelihood of somebody remaining well and surviving. But this has all been totally changed because while the number of lymph nodes involved matters, we also know that the biology really matters. So going back years ago, we started to be able to do these genomic analyses in tumors and break them out into different subtypes. And those subtypes track with whether the tumor is ER positive, PR positive, or HER2 positive or not. And when we look at these cancers based on their genomic discriminators, we see really big differences. So this is what like a triple negative breast cancer would look like, much worse survival in comparison to a cancer that is ER positive, HER2 negative. So this is where we get at the biology. And so a cancer that is a lower stage but triple negative could have a much worse prognosis than a cancer that looks to be a higher anatomic stage but has a better biology. So that has really informed how we do things moving forward. And we seldom talk about breast cancer as one disease. We talk about it being, node negative versus node positive, and there's a lot of focus on the node negative group because that's the group that we're at most risk of over-treating. And I'll explain a little bit more about that in a minute. But it also really matters amongst the node negative, whether they're triple negative, HER2 positive, or ER positive. So what does it look like when we do good? Okay, so I'm not going to talk about HER2 next. Give me 1 second. I'm going to stop sharing and switch to a different set of slides, and I will be right back.
Would now be a good time for
Yeah, any
some
questions from
questions?
that first part?
Feel free to type in the chat or unmute yourself and ask. I had a question. So you mentioned that the standards have changed a lot over time. Could you go into a little bit on, the importance of research in that change in standard? I also have a, question about, the disparities you briefly went over between, the developed and undeveloped world. It's my understanding that the U.S. is, one of the best in breast cancer survival. So if you could tie that in as well, I'd appreciate it.
Sure. So I'll answer your second question first because everything I'm going to show you from here forward is about the research and what we've done to improve things. So if you look around the globe, if somebody gets diagnosed with breast cancer in the US or the UK or the Netherlands or Australia, their survival rates are upwards of the mid to high 80s or better, depending on the stage of their disease. In comparison to if you start looking at India, that drops down to maybe about 65%. And when you get to countries like some of the sub-Saharan countries, the survival rates there are on the order of about 12%. So a breast cancer diagnosis is essentially a death sentence. And in part, it's because of lack of access to testing and treatment. But there, is also potentially some differences because even within the United States, if you look at a woman who gets diagnosed with breast cancer, whether she is white or Black will impact her likelihood of survival. Same thing, Latina. Those are the subsets of races or ethnicities that we understand the best. And some of the reasons for that biologic differences is not just it's not that they get diagnosed with different subtypes of breast cancer. They do. A Black woman has a higher risk of getting a triple negative breast cancer than a white woman would. But in general, all breast cancer in the U.S. is most often ER positive. And so why there are some differences in the biology and how some of these cancers behave is what's tons of research is going into right now. And some of it is disparities of economic advantage, access to the best of care, differences in practice patterns when doctors and clinicians are taking care of people who look one way or another, which is something that the field can change. It's a bias issue. But then there are also hardcore biologic differences about where our predecessors lived on this planet and how our immune systems developed and different aspects of our genes. And that's where a lot of the research is going into to also figure out, should we be treating women of different backgrounds racially or ethnically differently, because we can learn about different factors that are driving their cancers to behave differently, while we also need to work on the economic and cultural and bias issues that exist in our world, so that those are not also driving how care turns out. Does that answer your question?
Yeah, thank you very much.
Okay, so, and can you see a slide that says HR HER2 negative options for risk assessment?
Yes, we can.
Okay, great. So, so when I've been talking about figuring out the biology and some of the things that have evolved to improve how we are treating, what it really gets down to in the hormone receptor, hormone receptor positive. So that's estrogen receptor or progesterone receptor positive, HER2 negative subset. This is a group for which we know endocrine blocking drugs, things like tamoxifen or the aromatase inhibitors, do a great job of going after those hidden microscopic residual disease cells and killing them. But for many patients, that won't be sufficient, and they will still face a risk of recurrence for which chemotherapy could offer benefit. And so two major assays came along for predicting benefit. One of them involves 21 genes and one of them involves 70 genes. And they just look at the cancers in two different ways, but they both come up with an assessment of, will chemo offer added benefit on top of endocrine therapy for this patient? Two major large prospective studies have been conducted. One is called the TAILOR-RX and the other one is called the MINDAC. The TAILOR-RX uses the 21 gene assay, which is commonly referred to as Oncotype, and the MINDAC used the 70 gene assay, which is commonly referred to as MammaPrint. And so I'll go through that with you. So I'm going to focus on young women, but I'll explain how it differs between older women and younger women. When we send a woman in the modern era for a TAILOR-RX based result, getting an Oncotype on her, we get a recurrence score that comes back in one of these ranges. And so what this assay does is it takes a slice of her tumor, grinds it up, pulls the DNA out of it, and analyzes these 21 genes. 16 of those genes we know are the important genes that predict for how a cancer is going to behave, and the rest are just housekeeping genes that tell us that the assay worked. And so the recurrence score is nothing more than a way of recombobulating that genomic data into something digestible, because genomic data looks like that that heat map I showed you a minute ago with the red and the green and the genes that are up and down. I can't show that to a patient and say, well, based on what your red and green profiling looks like across 16 genes, here's what I recommend. So what the company that makes the Oncotype did that's very clever is they fit it to a mathematical formula. The formula weights the bad genes one way, the good genes the other, and it spits out a number. The number is a recurrence score. And that score is fit to 0 to 100 on a scale, because we've known since first grade how to understand 0 to 100. So anything above 26 is considered high risk, and everyone in that group would be requested to go on and receive chemotherapy on top of their endocrine therapy, because the benefits there start to get really big. Those are cancers that have risk much more similar to a node positive or more aggressive form of breast cancer. Within the 26 and under, if a woman is postmenopausal, so she's already, into her 50s or later, we do not see any benefit from chemotherapy. And so it is not recommended to an older woman. For our younger women, it's a bit more nuanced. And depending on where this score comes in at is whether they get no benefit from chemo, such little benefit that most of us would not recommend it, right? Because 1.6%, the serious risks of chemo are up around 2-3%. So that's not a territory where I would recommend chemo. Once we start getting up to the benefit of 6.5%, well, that starts to become a discussion point with the patient. And that's just exemplified here in terms of, I would say, the very low risk, the very high risk, quite straightforward. I'm not going to recommend chemo. I'm going to recommend chemo. I think this category is fairly straightforward, although I have seen some medical oncologists argue that chemo still needs to be discussed at this level. And here is the real nuanced range where it gets into a lot of shared decision making and a research opportunity. One of the things is when this study was done, all of our patients were only receiving tamoxifen for their endocrine therapy. And we've made some improvements into the field, which is called optimized endocrine therapy that I'll show you in a minute, which reduces their risk even further. So the thinking is if we give our patients optimized endocrine therapy, would we give them this level of benefit by just making their endocrine treatment better? And then we would still not need to give them chemo. And realize we are very chemo heavy in the United States. If a patient with a cancer like this was diagnosed in Europe, she would not be offered chemo. She would be treated simply with combination endocrine therapy. The MINDX trial is kind of similar. It used this 71 gene signature, and it would break out patients into clinical low or clinical high risk based on these types of features, tumor size, lymph nodes, different things, and then the genomic low risk score versus high risk score for recurrence. And if both were low, nobody wanted to give chemo. They just went on to endocrine therapy. If both were high, everybody would want to give chemo. And then depending on if they were clinically low, genomically high, or clinically high, genomically low on this trial, they were randomized to either receive chemo or not. And we have results of this group, the clinically high, genomically low. And what it showed is in the older women, they didn't really get benefit from chemo. In the younger women, there was a small gain. It was about a 5% gain if they received chemo. The most gain was seen in patients with higher risk, although it was weird when you looked at the node negative versus the node positive subset, that didn't really sort out as much of a difference. But some of the other features we can look at, like the grade of the tumor or the Ki-67, and particularly the age of the patient, seem to matter more. So there's been this trend in that younger women benefit more from chemo, so they will still get benefit out of treatment, even if their genomic profile doesn't look quite as high. And that was the same as what we saw with the Oncotype Taylor RX data as well. So this has moved forward to yet a next generation trial that was called the Responder trial. And this was taking the same concept, but doing it in women with lymph nodes positive up to 1, 2, or 3. Again, they had to be hormone receptor positive, HER2 negative. And they had to have a low risk recurrence score of 25. This study was using the Oncotype. And so here's the schema. This is who was eligible for it. And if they had a 0 to 25 recurrence score, they were randomized again to standard of care chemo followed by endocrine treatment or endocrine therapy alone. It was a big study, a lot of women, over 3,000 postmenopausal, 1,600 premenopausal, 5,000 in total. Always a smaller population that are in the younger subset. And when you look at the breakout of where they fell on the recurrence scar, were they the very low or the not quite so very low? It was a pretty even breakout of the patients who got enrolled who had either one of those. When we look at the premenopausal women, there was a advantage to giving chemotherapy across the board. The absolute difference in distant recurrence at the time of the first presentation, which was 5-year invasive disease-free survival, was overall about, the absolute difference was 5% in invasive disease-free survival, and then distant recurrence, meaning metastatic disease, was about 3%. So this includes local recurrences of an invasive nature. This is just distant metastasis. So that's that's considered a significant difference. For the postmenopausal women, they did not benefit from chemo, even if they had 1 to 3 positive lymph nodes, if their recurrence score was under 26. When we try and break it down of who amongst the premenopausal women were the ones getting the most benefit, nothing really stood out. Pretty much everybody was clearly benefiting, even if they were very young versus medium young. If they had a real low risk recurrence score, the difference was about 4%. If they had a higher low risk recurrence score. Their difference was about 6%, which is interestingly almost the identical number that we saw in the Taylor RX trial, really showing us that biology determines how these things come out. So based on this, it changed our field dramatically overnight. We get oncotypes now on women with positive lymph nodes. And if they are older and their score is less than 26, we tell them they don't need chemo. If they are younger, we could have a nuanced conversation about the merits of chemo. And because, I think with something as toxic as chemo is only going to offer a 4% benefit, that's not an automatic, right? That's a discussion point. 4% is not 40%. But a lot of women will still choose to do the chemo because they really want to minimize their risk. And this has led to the next generation of trials. Before I talk about that, I'll just go back. In parallel, at the same time, we were running these clinical trials of optimized anti-endocrine therapy for our younger women. The standard of care treatment for them had been tamoxifen for years and years and years. And what we know from older postmenopausal women is if you compare tamoxifen to these newer drugs, and when I say newer, they've been around since the 1990s, as opposed to tamoxifen, which has been around since the 1960s, so newer. But in postmenopausal women, we did decades of research to show that the aromatase inhibitors were about 4% better than tamoxifen on balance across all the studies. So this was a recent study from the 2000 era where we took younger women and we made them chemically postmenopausal by shutting down their ovaries with injections, drugs like Lupron or Zoladex. And then they were either randomized to tamoxifen alone, tamoxifen with the ovarian shutdown, or an aromatase inhibitor. In this case, it was exemestane or aromasin, plus the ovarian function shutdown. So if you make a woman chemically postmenopausal, you can still use these aromatase inhibitors. If you don't make her chemically postmenopausal, you are giving her a fertility drug. These are the same drugs the reproductive endocrinologist would give a woman who is needing to undergo some form of IVF or supported reproduction to get pregnant to try and drive the eggs into circulation. So we really want them to have their ovaries shut down before we give them these drugs when they're getting treated for breast cancer. And what this study showed us was that the combination of the ovarian function suppression plus either tamoxifen or the AIs were significantly better than just tamoxifen. And the advantage was seen in women with higher risk disease, so positive lymph nodes, nasty looking cancers, and worse biology. But these studies were overlapping between the two. So what we don't know is if we had all of our young women on optimized endocrine therapy, and we used something like an oncotype or a mammoprint to figure out if they were high or low risk at a genomic level, would we still need them to undergo chemo? And that is actually the subject of what will be the next cooperative group study that will be coming forward soon, BR009, also called the Offset trial, that will be asking that exact question. All those women will get optimal endocrine therapy, and then they either will be randomized to chemo or not. And that will be lymph node positive young women's breast cancer. Any questions for me on all of that? I don't see any hands up or anything in the chat. All right. Am I boring you guys, or is this good?
It's great.
Okay.
Yeah, it's very interesting.
All right. In the last 15 minutes, I will give you the whirlwind tour of HER2 positive breast cancer, which is one of the other important subsets. We're not going to be able to cover triple negative breast cancer, but you guys could always invite Dr. Diamond in to give a talk on just that, including in the metastatic setting, which is super interesting because that's where we're doing a huge amount of drug development and have made a lot of progress. And that look fine? Okay. So in about the 1990s, actually it was the late 80s, this gene was identified in breast cancer that was called, well, it was originally called, the gene is called ERB-B2, and when the protein is expressed on the surface of the cancer cells, it's called HER2. So you have to realize at the start of my career, this was brand new information, and HER2 didn't just roll off the tongue like it does now. And this was identified as making cancers behave very aggressively. And it's an interesting gene and protein. It's from a family. So HER1, you guys may recognize as what we also call EGRF, so a big player in lung cancer and other diseases. HER2's been a big player in breast cancer. It has a HER3 and a HER4 companion as well. And HER2, when it is bound to one of its siblings or bound to itself, will start to cause downstream signaling inside the cancer cell that leads to a lot of cell division, a lot of invasiveness, capacity to spread, and just be a very aggressive form of breast cancer. And in the clinic, the way we look for this is we take tumor tissue and we either do staining to see the HER2 protein, which we call IHC. And if it's 3+ positive, that's what we've called positive all these years, or we can do a test where we look for the presence of the HER2 gene, the red things here, in relationship to the centromere of chromosome 17, which is what HER2 sits on. And if the ratio is higher, that means there's too much of this gene and it's called amplified. Or if it's normal, it's what it's supposed to look like in healthy cells. And you realize HER2 is in every single one of our cells. It's in about 1/4 of all breast cancers that it becomes altered like this. And we call cancers that are 3+ positive or amplified HER2 positive. And this leads us down a very specific treatment pathway that I'm going to talk about in a bit. Recently, we've also begun to realize that we can target tumors that have a little bit of this protein expression. So while the HER2 is not the driver mechanism, it's not the true HER2 subset of the breast cancer, but we can use it as a target to get some of our novel antibody drug conjugates into the cancer cells, even if they have just a little bit of expression. So we now start to talk about patients who have HER2 low positive cancer as well. And this is going to continue to evolve over time. In 1998, we also saw the clinical trials related to this drug, trastuzumab, which was the first monoclonal antibody for any cancer, the first targeted therapy other than estrogen targeting drugs that we had. And it was a revolutionizing drug. It became FDA approved for metastatic breast cancer and then launched into a large series of cancers in the early breast cancer stage. All of these resulted around 2005, 2006. So this was the standard backbone of chemo, the ACP, which is Taxol, or the ACD, which is Taxotere. And all of these studies had pretty uniform results in that the incorporation of Herceptin on top of the standard chemotherapy reduced the risk for recurrence by half. And I'll just draw your attention to this one. This was a European international study. We participated in it too. And it was the one study that had a novel chemo regimen that didn't include Cytoxan and adriamycin. It was Taxotere, carboplatin, and Herceptin. And this came out of the lab of Dennis Slayman, who invented Herceptin. And it was very rationally designed based on the synergy of what they were seeing in the lab of what would kill cancer cells the best. So this is an example of the improvements in disease-free survival with the anthracycline or just the TCH regimen. There was a marked improvement over just chemotherapy alone, and these became the new standards. Once we knew that these were good regimens to use in the adjuvant setting, we rapidly moved these into what we call the neoadjuvant setting. So in breast cancer, we like to give chemo first if the tumor is larger, and we figured out in HER2 positive breast cancer that it was super important to give the chemotherapy first, because finding out whether all of the cancer would be dead by the time a patient went to surgery by giving the chemo first, or the pathologic complete response rate, is a real driver of how we can determine who's going to be cured from their breast cancer or not. And so there were a myriad of studies done in this space at this time, and this is just some of the bigger ones. But you can see that whether they were using an anthracycline like adriamycin, in this case, it's a cousin called epirubicin, or not, we were using just one of these taxane Herceptin-based regimen. And pertuzumab is another monoclonal antibody. You can think of it as first cousin to Herceptin or trastuzumab. That had come along in the metastatic setting. So now we were combining these two biologic drugs in combination with chemo, and we were seeing huge improvements in our ability to kill off all the cancer cells by the time the patient went to surgery. And this regimen, the TCHP, kind of became the gold standard out of all of these trials. The other reason why we were super interested in ditching the adriamycin harkens back to something that we did in the late 90s. We didn't know that if you overlapped Herceptin with adriamycin, you would cause an astronomical amount of cardiomyopathy. From the clinical trial that got Herceptin FDA approved, the rate of cardiomyopathy was 24% in the patients that received direct overlap of adriamycin and Herceptin. So that's now considered absolutely forbidden to do, and the drug has a black box warning. But even when you did them in sequence, the AC first and then the Herceptin later, there's still about a 4% risk of cardiomyopathy, which is a pretty fatal illness in and of itself. So that's why we were very motivated to get rid of the adriamycin, and TCHP caught on as our preferred standard of care. We also did a clinical trial called Affinity. I mentioned pertuzumab and that it had come along later. So for the longest time, after we gave TCH or TCHP in the adjuvant setting, the patient would then stay on just Herceptin for the completion of a full year. And then the Perjeta came along, and so we didn't know if we added the pertuzumab or the Perjeta on top of the Herceptin, would it improve outcomes? So that was the Affinity trial. This was patients who had had upfront neoadjuvant treatment, and then they went on to stay on both drugs in the adjuvant setting. And it improved the overall invasive disease-free survival, but the improvement was really dominantly seen in the node positive set. So that's now our standard. If a patient is node positive, they will get TCHP in the neoadjuvant setting, and they will stay on HP in the adjuvant setting unless. So I'm going to skip forward just because we're running out of time. I'm not going to go through all the studies we've done in this space, but just focus on one other. So there was a study that we did a few years ago called the Catherine trial. So this was looking at women who got upfront neoadjuvant chemotherapy with something like TCHP. And rather than continuing them on just the Herceptin and the Perjeta, they were randomized to either receive that or to receive another new drug that had come along. This drug is called Kadcyla, or its generic name is atotrastuzumab emtansine. So we call it Kadcyla, or TDM1 for short. And this was a slam dunk clinical trial. We improved the freedom from distant recurrence. We improved the overall survival. And as you can see from this chart, where anyone who's on this side of the line is the one who derived improvement from the TDM1, no matter what the feature of the cancer was or the different types of people who got enrolled on this trial, everybody benefited. So that is now our new standard of care. Is if they don't get the PCR and they still have living cancer in their surgical specimen at the time of their operation, we upgrade them and give them the Kadcyla afterwards. And what that has led us to be doing now in trying to make improvements in the field is the next clinical trial that's been ongoing is this set of studies called the Compass HER2. And I'm actually one of the NRG chairs on this one called RD, which stands for residual disease. So what this looks like is for the same population of patients, a little bit higher early stage disease, HER2 positive, instead of giving them 6 cycles of TCHP, which has a lot of toxicity, we get rid of the carbo and we give them the THP for 4 cycles, which only takes 12 weeks. And it's much easier to give. And then we take them to surgery. And if they've had the highly desired PCR, we keep them on the H&P for a year. They'll also get endocrine treatment and radiation based on what they need. If they don't get the PCR, they have to get more chemo, which most of us would give them 2 more doses of the same thing. And then they either get escalated to the standard of care TDM1, or they come on to the Compass RD trial. which looks like this. So they get randomized to either just TDM1 or TDM1 plus my favorite drug, tucatinib. This is a pill that is targeting HER2. And when these two are combined together, we think it's going to be better. And one of the important things it's going to add is that our HER2 positive patients have a very high risk of getting brain metastases when they get metastatic disease. And in the Catherine trial, the TDM1 didn't improve that. But from the metastatic setting, we know that tucatinib can treat brain mets. So we hope this study is not only going to improve the cure rates, but it's also going to eliminate the number of women that we see facing brain mets into the future. So in the interest of time, I'll stop there. And I see there's one question in the chat. Oh, it's great. Thank you. Thank you. Why don't I take questions in our last 3 minutes or so? And if there's anything that was really burning in your mind that you hoped I was going to talk about in early breast cancer that I didn't cover, feel free to also ask that question as well.
Dr. Borges, what is some of the survival rate if a patient has more comorbidities than going in as sort of a healthy person with breast cancer, but not you're adding in other diseases they may already have?
Yeah, that's a fantastic question, Tanya. So things that influence breast cancer outcomes, diabetes, particularly type 1 diabetes, has been shown to affect how women get diagnosed with. So increased frequency of getting breast cancer if they have diabetes or type 1 diabetes in particular. And then there has been some evidence to show that there can be worse outcomes. That's older evidence, and we have better anti-diabetes drugs now. So I think we might be leveling the playing field there. The other one that doesn't go in women's favor is their body mass index. So if a woman has a BMI that registers into the overweight or obese or higher levels, she's much more likely to get diagnosed with breast cancer, particularly when she is postmenopausal. And the outcomes look worse for that. And it makes sense because both diabetes and obesity or having an elevated BMI is associated with generalized inflammation in the body. And breast cancer is a disease of inflammation, and how well people survive breast cancer or get cured is based on how well we do at getting rid of the cancer cells, but also changing the body so that the cancer cells don't have as much likelihood of surviving in the body. And the best way to do that is to decrease inflammation. So one of the best ways to reduce someone's risk of breast cancer or their risk of recurrence or improve their survival if they have metastatic disease is to get them exercising. And so there was a clinical trial of women with early stage hormone receptor positive breast cancer. And the intervention was simple. They were asked to walk on a treadmill 1 hour, 3 times a week at a moderate pace. And that alone had the ability to reduce the risk of recurrence by an additional 50%. So if you ever hear me harping on exercise with my patients or complaining that I didn't get enough exercise this week because I was getting my notes done, it's because it's just so vitally important that all of us be incorporating this into our lifestyle. So does a breast cancer rash present with any other symptoms? So I think there's 2 questions woven into that. So anyone who develops something that looks like a rash or an infection in their breast should go see their doctor. Many women, particularly women of childbearing age and nursing women, can get mastitis, but we want to make sure that that's all it is. And a mastitis that's not responding to treatment, we need to raise our concern or our suspicion. Could this be an inflammatory breast cancer presentation? Breast cancer itself, any changes in the breast, a lump, a divot, the nipple changing shape, retracting, any lump, lymph node under the arm or up in the neck area. If it's, if it's found and it's still there, a week later, that should prompt a woman thinking about going in and seeing her doctor. If a woman feels a lump in her breast and she's prone to lumpy breasts like cysts or fibroadenomas, a doctor will usually have her follow it through one cycle of her period if she is getting periods. Pregnant women are not getting periods, so a woman who feels a mass in her breast during pregnancy should have that evaluated. Or if she's postpartum and lactating and her periods haven't turned back on yet, same thing, she should go that evaluated. A postmenopausal woman is no longer getting her period, so a lump in the breast should trigger her to go in and see her doctor and have an ultrasound. Plenty of things happen to women's breasts that are never going to be cancer, but early detection is key to both not having to have to go through all of this treatment and also our survival outcomes. So we want to find as many cancers at stage 0 and stage 1 as we can. Jessica, you threw your hand up.
Hi, Dr. Borges. Great presentation. Thank you. I just had a quick question. So back to the exercise piece. Would you recommend someone who is currently going through chemo to exercise or to wait till after, like start now, or do like, the mile on the treadmill or 15 minutes or something like that?
So a woman with breast cancer going through chemo, I would for sure recommend that she be continuing some level of exercise. And depending on how old she is, what type of exercise she was capable of doing before is what that would look like. So, in my young women's breast cancer clinic, I have patients that can beat me up the stairs even while they are on chemo because they are young, incredibly fit women. And I want them doing their usual thing as well as they feel up to it. Now, when we give chemo, there's some bad days and then there's some better days. So if they don't feel up to it like 2 days after chemo, okay. But by the week before they're coming in for their next cycle, we want them doing that. Now, that's a little bit different than my colleagues who are seeing patients who are maybe, 75, 80 years of age. There are fragility tests in geriatric oncology, and there are methods by which we can assess an older woman or man and if they are going to do okay with some of the more aggressive treatments or not. But even for them, we really want them to be doing something. Even somebody going from sedentary to just 20 minutes of walking a day will improve their functionality and their outcomes. And it's important because people tolerate their treatment better if they are fitter and even getting a modest level of exercise. And I don't know if you guys know, but we have this thing on the edge of the campus called the Wellness Center. And there's the Be Fit, Be Well program within the Wellness Center, which is specific for our cancer patients. And Dr. Cabos, my colleague on the breast team, took that over, I don't know, within the last 12 or 18 months. And there's exercise programs based there. There's also research programs based there to figure out what are the best types of exercise, how much, what should we really be guiding our patients to do to have hardcore outcomes of, reducing recurrence or improving survival. For now, I would say anything's better than nothing. And I tell my patients to do what they like and what they're most likely to stick with. Now, I don't really want my rock climbers rock climbing while they're on chemo because we do mess up their focus and their thinking and their balance. And a big old broken leg in the middle of chemo is a bit of a problem. But, they want to be on their bike. They want to be hiking. They want to be just walking the dog or whatever. All of it is fine. And I strongly encourage it. The other thing we also have to really encourage our patients towards, and it's not just breast cancer, but all the treatments we give, and particularly when we start taking away estrogen in women or testosterone in men, the prostate cancer guys, we start to lose our muscle mass, and that is called sarcopenia. And people don't feel well when they lose their muscle mass, and they can become more frail as they age. And so all of us should be getting out our weights and doing our Arnies and keeping our muscle mass strong, particularly as you start to round my age and even older. But for our cancer patients where we are causing some of this in their lives younger than it might otherwise happen, or they were already older and already suffering this risk and now we're making it worse, that's why the Be Fit, Be Well program is great because it focuses on that. But this is something people can do on their own. Even a soup can is better than nothing. Or they can go to their local rec center or something, but we definitely want them moving. Moving is survival. All right, thanks guys.